the one who is who is a renowned personality in anesthesia and has got such an experience in academics and teaching and everything. So we are really grateful to you. I'll be giving your intro in a short while, and we will be starting your presentation very soon. But we usually wait for 5 to 10 minutes after 8 o'clock so that most of the people who are about to join, they join. Usually, sir, there are 40 to 50 participants who regularly joins PSA Karachi online lecture series. And there is one more thing, that we do have a format that we speak only in English, even when answering the questions, because we have some of our participants who are participating from Nigeria, Myanmar, and other countries, and can understand only English, not Urdu. So that's why we try to answer them in English as well. So that was just a basic format of PSA online lecture series, and inshallah we'll be starting your talk very soon.
Thank you very much. So I have already shared the screen. Is that okay with you?
Yes, it is apparent and we can clearly see it.
Okay.
And
Just post it the
I'll
title, yeah.
intimate you when we'll be starting.
Sure.
So, sir, just a brief backup of whatever we have been doing. Actually, we do take questions, but the questions are being answered at the end of the talk or the presentation. So we will be taking them on on the chat, and once you will finish your talk, then we will be open to the question and answers.
That's fine with me. Whatever format you want me to follow, I'll follow that.
That's so nice of you. Thank you so much.
Assalamualaikum, sir.
Assalamualaikum ji.
So nice to hear you, sir. I was your student when you were my examiner in previous exam of MCPS. Dr.
I
Humaira.
hope Dr. Humera, I hope I was not unfair.
No, sir. Sir, I was passed and now I'm doing fellowship again after
Oh,
so
really?
much. Yes,
So
sir.
where are you working these days?
Sir, I'm in Pindi now, Islamabad.
Great, great, great.
Dr.
Yeah,
Arshad
right.
Humera is also one of our regular participants. She has been actively
Wonderful,
participating. Yes.
wonderful. I mean,
So glad
great
to
to
hear
know that
you.
you've gone national. Uh, uh, God bless you for doing what you're doing, Dr. Asma.
Thank you, sir.
Uh,
Thank you so much, sir. I'm really blessed to have seniors and faculty like you and many others who are just not favoring us, but also be on that level who can, actually support such kind of residents who don't have access to these teaching sessions and academic activities. So I'm really grateful to you, despite of the fact that we do started it, but obviously you, all of you, not our faculty from Karachi, but the faculty from Punjab and Peshawar and other faculties. You are all are part of this, the success of these online sessions. So we are really grateful to you. Without you, it would not have been possible for us to conduct all these lectures with such consistency and continuously. So thank you so very much, sir.
whatever little like we can do, that would be a pleasure. And uh, let's just accept that this is our pay forward, as they say. There were, when we started our anesthesia, uh, and I must say, I got a call from Professor Dr. Akhtar Wahid a little while ago, and he was one of
Ji.
the people who actually held our hands and helped us becoming what we are, whatever little that we are. And it was people like him and Professor Tipu Sultan, like people like Dr. Call, Brigadier Salim, and so many other names that I may be missing. So we owe it to those and to the specialty. Whatever we are because of what because of this specialty. And no matter what people say, this specialty has given us so much respect, honor, good lives. Uh, I hope people who are following us also feel the same about it. And I'm sure this is going to be a
Uh,
great life.
that is so true, Dr. Arshad, because people like you or other seniors, like we have so many people, so many stars on PSA, Tipu Saab, Dr. Saida, we have Dr. Amin, who was our ex-president, but who was actually with me, who started all these online lecture series, and so many other seniors from all institute, and especially now from those who are contributing online from the other part of the city is a big is a big thing for us, all of us, because the support which you guys have given us in all these time periods is like tremendous. So we are really thankful to you, sir. So without any further delay, because now for 35 participants have already joined in, I'm expecting more to join in. Can I please give your introduction to my participants? So, Dr. Arshad, we are really thankful, Dr. Arshad, for you to join the PSA online lecture series. Dr. Arshad has served as supervisor and examiner of FCPS anesthesiology since 1998, and currently he's also a supervisor of critical care medicine program. He started his career as independent practitioner back in 1986 from DHQ Hospital, Jhelum, and later on, it was expanded to many more beds from where it started. Then he also established and served as the head of Department of Anesthesia and Children Hospital, Lahore, from 1998 till 2001. Dr. Arshad Taqi has been working as a consultant anesthesiologist and critical care with Call Associates since 2001. And from there, he also started postgraduate training programs and provided the clinical services in anesthesia, pain, and critical care in multiple private run tertiary care hospitals all over Lahore. Dr. Arshad Taqi has recently joined Indus Hospital and Healthcare as consultant anesthetist and pain management, where Indus Hospital has a capacity of 600 beds. with NSTQF Campus, Lahore. Dr. Arshad Taqi is also a founding member and faculty of the Critical Care Medicine at CPSP, which is College of Physicians Pakistan, Physician and Surgeons Pakistan. And he has actively contributed in the development of FCPS critical care program in the country. And he was also the ex-president of Pakistan Medical Commission, and he served there from October 2022 to August 2022. So I'm really grateful to Dr. Arshad Taqi. Thank you so very much, sir, for joining us today for the PSA online lecture series. I'm looking forward to your talk on your topic. Thank you so much, sir.
Thank you very much. Thank you for this opportunity. And I must say, and I've been saying for this for the last few minutes as well, all credit to the great PSA team. They are always the pioneers, flag bearers, and they come out with all those innovations which serve the specialty so well. So without any further delay, I'll come to the topic. And let me begin with my inspiration for selecting this topic, because when Dr. Asma asked me what would I like to talk about, I reflectively said I'm going to talk about intraoperative hypotension, a subject pretty close to my heart. And the reason why, when I started my career and we started our fellowship trainings and came to know a little bit about research, at that point, one of the hot topics that everybody took for their synopsis and dissertations was obtending the stress response, hemodynamic response to laryngoscopy and intubation. And you would talk about the beta blockers and the opioids and whatnots that you would do to ensure that the patients do not have that rise in blood pressure and heart rate during induction, which we thought was so bad for the patient. So that's why that actually got me interested on what is really bad. We know that hemodynamics, maintaining normal hemodynamics is integral to the process of anesthesia care. ASA standards and all other standards make it mandatory to continuously monitor blood pressure, which we either as non-invasively or invasively throughout anesthesia, and that's a mandatory standard of care, as I said earlier. So why is it important to measure blood pressure, and what are those limits within which when we are supposed to target it, and what happens when we do not maintain those limits? So I'm going to talk about generally the way the knowledge has evolved on this subject and is still evolving. I'm not going to talk about treatments, unfortunately, because that's another topic. It's an altogether different topic on how to manage intraoperative swings in blood pressure, particularly hypotension. So I'll start this presentation with a scenario that you come across every day. I'll just see if, yeah, the slide is. So are the slides moving? I just want to make sure that the slides are moving and you can see the new slide. Can you do that? See that, please?
Yes, sir, we can see the preoperative challenge slide.
Yeah, preoperative challenge. Yeah. So this is something that we come across every day. We come across patients who are on ACE inhibitors and ARBIs. And there is this kind of the caution about their use. And you're always wondering whether to stop them on the morning of surgery or to ask the patient to continue. And the consequence is that if you stop them, you are risking a rise in blood pressure at the time of induction. If you continue them, there's this risk of hypotension. And the recent European Society of Cardiology guidelines, ESC 2022 guidelines, do talk about this subject, and they suggest that majority of studies suggest that continued use of these is associated with high risk of perioperative hypotension, higher use of consequence vasopressor inotropes, intraoperative hypotension, and its duration is associated with end organ damage, including kidney injury, myocardial damage, and stroke. So they do acknowledge that intraoperative hypotension and its duration is associated with end organ damage. Uh, and then they go on and specify the organs that they uh, suggest are involved. And also, so this brings us to the question, when we have this kind of query, first question, which is that if we are stopping, continuing those are ARBIs, AC inhibitors, and we are talking about the possible risk of hypertension versus hypotension, which one would be a greater, has a greater chance of causing harm to the patient? This question was taken up by Monk and their group in 2015. So what they did was, this was a very elegant study model. What they did was, and most of the studies that we will come across in this presentation are based essentially on the fact that now with the electronic anesthesia records and patient management systems, what we have access to very huge, large amounts of data on intraoperative patient data. So then you can actually, with the right kind of tools, analyze data of hundreds of thousands of patients. So what they did was they went ahead and looked at the intraoperative behavior of patients who developed hypertension or hypotension, and then looked and followed them and saw, retrospectively went and saw whether these are like classic retrospective but case control studies, because they identified those groups and saw which one of them were living and which one of them were dead after 30 days. So they were looking at 30-day mortality in patients who had hemodynamic swings during anesthesia. And as you can see here in this graph, that they are looking at not just magnitude of the drop in blood pressure or rise in blood pressure, but also the duration for which it persisted. So, and what you will also find here is as this broken line here, which says -2 standard deviations, and up there are +2 deviation from the mean. And we'll talk about that in a little while. So this is what they were looking at, and what they found was the conclusions. So before we go ahead and talk about conclusions, I'll just talk about say a few words about the journal study design of most of the studies which have addressed this issue. And most of these studies are about looking into retrospective data or even prospectively looking into that data to see what is, if there is an association between intraoperative hypotension, and in this case hypertension, and outcomes, which means end organ damage or death. So what they also while they're looking at this data, we must realize one thing, that there are so many confounding variables in these studies, because patients, when you're looking at that composite of all patients undergoing non-cardiac surgery, then you may have patients with pre-existing heart disease, pre-existing renal failures, pre-existing patients who have had excessive bleeding during surgery, patients who have underwent more expensive surgery, longer duration surgery, shorter duration surgery, patients who had a period of hypoxia during surgery. So there's so many variables that can influence these results. So the one beauty of this large data is that they managed to tease that data, and then match the two populations when they are looking at by actually doing some kind of statistical analysis that is beyond the scope of this. So based on whatever they found, they saw that a 30-day mortality was associated with systolic blood pressure less than 67 millimeters of mercury for more than 8.2 minutes, a mean arterial blood pressure less than 49 millimeters of mercury for more than 3.9 minutes, and diastolic blood pressure for more than of less than 33 for more than 4.4 minutes. In terms of odds ratio, what do you mean by odds ratio? Which means for every one patient who did not develop hypotension and died, there were like 2.9 patients who had a systolic blood pressure less than 70 millimeters mercury for more than or equal to 5 minutes, had a 2.9 times more chances of dying. And same goes for mean arterial pressure less than 49 for 5 minutes or more, or a diastolic blood pressure less than 30 millimeters of mercury for more than 5 minutes, actually had a 3.2 times more chance of dying within 30 days. Once again, this was absolute. As we can see, they're talking about an absolute value, which means a given number to the systolic, diastolic, and mean blood pressure. But a lot of people actually talk about a change from the baseline, which means that they take some blood pressure taken at some point before anesthesia as the baseline, and then they look at the percentage change from that baseline as a marker of outcomes. And what they found was that when they analyzed the data on that basis, what they found was that you had a 2.7 times more likelihood of the patient had a 2.7 times more likelihood of dying within 30 days if the mean arterial pressure decreased by more than 50% or equal to 50% from that baseline, whatever that baseline was. The second observation in this study was that intraoperative hypertension was not associated with 30-day mortality. So now we have these numbers and we have these kind of definitions. So, but before we go on and take these as absolute values, we have to look at a little more, like all this little more critically. And what we need to look at is a standardized definition of hypotension, which means, are we talking about predefined thresholds, which means, as in this study, they said a blood pressure less than 70 millimeters of mercury. And what they did was they actually divided the patients into various cohorts, which means they looked at patients who had a systolic blood pressure of less than 70, mean arterial pressure of less than 70, a mean arterial pressure of less than between 65 and 70, a mean arterial pressure between 60 and 61 and 65, then 55 and 50, and then 50 to 55, and then less than 50. So they actually looked at those different population cohorts and looked at how they behaved. And then they also looked at the duration of hypotension. But what we are seeing here is that they have actually a predetermined number on the basis of which they are defining those thresholds. But as you can see that, and you could see in that line, that there were also one way of measuring it is a percentage, a change from the study population mean. I mean, when you say diastolic blood pressure of less than 65, then you are assuming that this is the normal in the population, or based on our understanding of physiology, wherein we say that the limits of a lower limit of autoregulation is like 60, then we will take a mean arterial pressure of 65 as that a standard below which we think the organ perfusion would suffer and there would be adverse effects. But then you can actually talk about the population mean, which means mean blood pressure in that particular population that is being studied, and see if a 2 standard deviation fall from mean actually can cause harm to the patient. The third way of measuring it is to see the deviation from patient's own baseline, which means I say that the patient's resting blood pressure when we conducted their preoperative assessment in the preoperative assessment clinic or in the pre-op holding area or before induction of anesthesia, you take one of that as a baseline. I remember about more than 10 years ago looking at a dissertation from Arshad University Hospital in which they had tried to define what was the baseline pressure, and they had looked at the pressures measured in the pre-op clinic and in the pre-op holding area and saw which one best fitted the definition of. But then you also look at the effect of duration of hypotensive episode. So whether it is the duration matters or not. So would it matter if the duration of hypotension was 5 minutes or 10 minutes or 20 minutes? So this is the second way of looking at hypotension. Interestingly, the Becker in 2007 tried to address this question. And then they searched the literature on all published articles in 4 major journals, which means anesthesiology, anesthesiology, British Journal of Anesthesia, and anesthesia. And then they identified 140 criteria, or looked at 130 articles, and they saw that there were 140 different criteria to define hypotension. This is a rather crowded slide, but what you'll see is that if you take one as less than 100 as systolic blood pressure as that standard, then what we'll find is that for every 1 minute, the likelihood of having an adverse event changes from depending on if we take this less than 100 as the standard, then the frequency of hypotension increases. Because if we are saying that we'll say that we will define hypotension as a systolic blood pressure less than 100, then actually, according to some studies, 81% of the patients would actually have developed hypotension at some point during the anesthesia. Whereas if we change this definition to less than 65 systolic pressure, then only 14% would be that frequency of hypotension. And if we change it from 1 minute to 5 minutes, then it would be 2.4% and 10 minutes, 0.7%. So if we keep on bringing the levels low, the frequency of hypotensive patients who developed hypotension decreases. But then, as we will see, the outcomes also change. And for that, once again, the same group went on and in 2009 looked at the effect of intraoperative hypotension on 1-year mortality after non-cardiac surgery. So what they did was they defined hypotension. They looked at different definitions of hypotension, which means four definitions of systolic blood pressure, 4 definitions of mean arterial pressure, and 4 thresholds relative to baseline, which means a decrease of 10%, 20%, 30%, 40%. And then they looked at minimum episode duration of 1 minute, 5 minutes, and 10 minutes. And then they looked at all-cause mortality. So they looked at it in different ways and saw on the effect of 1-year survival on the basis of these different definitions. And they studied 1,705 general surgery and vascular surgery patients. And what they found here, and this you can see on multiple different ways, what they looked at is the hazard ratio. Hazard ratio is the increased risk of the patient dying at the end of 1 year. And if you look at this plot, and you can follow my arrow, and down here is the blood pressure in the first diagram, in the A diagram, and the second is once again the threshold values as they change, and then they have looked at percentage change from the baseline. And in the three columns, they are looking at 1 minute, 5 minute, and 10-minute duration of hypotension. And as you can see, as the threshold comes down from 100 to 80 and 70, below 70, there is a sudden fall in the increase in the likelihood of patients dying due to hypotension at 1 year later. So what we are finding is, once again, that as the duration and the intensity of hypotension increases, the likelihood of those patients having died at the end of 1 year increases. And the reason is that this actually set into motion certain processes, which means the process of acute chronic kidney injury, myocardial damage, which then goes on and multiplies, and by the end of 1 year. So this was the basis of people proposing that your anesthetic management is does not finish when the patient wakes up and everything is all right, but your interventions during anesthesia can actually influence your 1 year mortality as well. So the next one here is the relationship between intraoperative mean arterial pressure and outcomes after. So now this watch, what he did was, and this is so far the biggest study on this, once again, retrospective, looking at big data. And what they did was they looked at more than 330,000 cardiac surgeries performed. And they looked at the likelihood of these patients developing acute kidney injury or myocardial damage, infarction, if the patient has mean arterial pressures of less than 55 or less than 60 or less than 65 or less than 70 or less than 75. And once again, time duration during which this blood pressure hypotension persisted. What they found was that acute kidney injury developed in 7.4% of the patients who had hypotension. Composite, I'm talking about the composite. Myocardial injury developed in 2.8% of the patients who developed an episode of hypotension. Cardiac complications developed in 2.8%, and 1.5% of those patients actually died within 30 days, the patients who had a period of significant hypotension. And what you find here in these two graphs is that there is this sudden shoulder on this curve, that if you look at the curve on the left, that is the probability of patient developing acute kidney injury. And as the blood pressure, the likelihood decreases from, and you're moving from right to left, you're moving from 80 to 70 to 60 to close to about 55, and 55, there's a shoulder, and you suddenly see a steep rise in the incidence of patients developing acute kidney injury. So based on this and the subsequent studies, what we are looking at is a period of mean arterial pressure of 55 is where you see this shoulder. So, and if we go back and look at our anesthetic practice, and I'll just go back and look at to our real life. What we do is we have a patient, we are very conscious of this patient not developing hypertension and tachycardia at the time of induction. We induce that patient. In today's world, with laparoscopic surgeries, with complex spine surgeries, with those orthopedics and lots of endoscopic surgeries, they have a long prep time and a shorter operating time. And in that prep time, the patient is lying unstimulated. And often we find, and particularly when we are going for non-invasive blood pressure, the next reading you find the patient's blood pressure is like 50 mean arterial pressure or even 45, and sometimes we immediately intervene. But generally our interventions are short term. We give a short acting vasopressor or a pressor drug. Why? Because we are assuming that in a little while this patient is going to be stimulated by the surgeon, and then we'll have a sudden surge of blood pressure. We don't want that. So we tolerate this hypotension, just assuming that in a little while it will be okay. So what it looks at, this study that looks at, if you look at this forest plot on the right side, what and looked at the adjusted odds ratio, what you find is that if the blood pressure, the duration of blood pressure actually matters a lot. But then looking at the left, and what we'll see in the data subsequently is that when the blood pressure fall is below a certain limit, then even the duration becomes of lesser importance. And this once again was a very elegant study. What they call is are the nested case control studies. So they are like a little more powerful in case than the usual case control studies where you identify a population and follow them for that outcome of interest. In these cases, you are actually statistically taking care of the confounding variables which can influence the results. And what they looked at was the likelihood of patients developing myocardial infarction within 30 days of surgery. And what they did was they took two sets of patients, one patient who had developed myocardial infarction within 30 days of surgery, and the other matching control, which were controlled in all those possible confounding variables who did not develop MI. And so what they looked at was, and they defined intraoperative hypotension was that there was at least one event of absolute decrease in systolic blood pressure from preoperative baseline lasting more than 5 minutes. And what they were looking at was they looked at 4 quartiles. So patients who had a 20 millimeter, less than 20 millimeter fall, a patient who had 21 to 40 millimeter fall, those who had 41 to 50 or greater than 50 millimeter fall. And they identified 326 cases who had developed MI. And the MI cases, once again, the patients who developed MI had greater incidence of acute kidney injury. Type 1 MI was in 81%. Most of them had type 2 MI. And I'm not going into that discussion of the types of MI. That's for another day. Median time, and I hope probably that has been covered in the last lecture as well. Median time for surgery during which MI occurred was 2 days. And what this study all showed was that if the difference in drop in blood pressure was greater than 50 meters, the odds of this patient dying was actually something like 20 times more. So a patient who had a greater than 50 millimeter fall in this study had a 20 times greater chances of dying in the first 30 of developing a myocardial infarction within first 30 days of surgery. So this is a huge fall. Once again, another study which looked at myocardial infarction by measuring T4, the troponin levels. And once again, what you're seeing is what this study did was, and how this study was different was that it actually identified the risk factors for developing myocardial infarction previously. And so they identified those risk factors. They defined intraoperative hypotension as fall in systolic blood pressure of more than 50% from baseline for more than 5 minutes. And what they looked at was that they concluded was that this was an independent predictor of myocardial damage on postoperative day 1 and MI within 30 days of surgery, independent of baseline risk. So what they did was they made sure that they were actually taking care of all those variables which could influence the incidence of myocardial infarction. And still they found that taken care of those variables, the fact that this patient had a more than 50% fall in systolic blood pressure for more than 5 minutes had a greater likelihood of dying of having an MI within 30 days or damage within 1 day. And now this study is very interesting. This is by Weslenk and the colleagues and was published in British Journal of Anesthesia in 2018. Because as you can see that so far we have been looking as hypotension in terms of like discrete numbers, greater than 65, lesser than 65, 55, less than 55, 50 to 55. This gives an impression that somehow if the patient's blood pressure is 54, he is more likely to die. And if it is 56, then it is going to be okay. No, it doesn't happen that way, because giving those discrete, compartmentalizing them on the basis of these discrete numbers does give us this impression, and also gives people a defense that, hang on, I kept my blood pressure more than 65 millimeters of mean arterial pressure. So this alone does not really satisfy the thing. So this study actually, instead of looking at the discrete numbers, they looked at the relationship between hypotension, duration of hypotension, and the risk of developing myocardial infarction. I'm not going into details, but what it looks at is those different combinations of short duration of hypotension of intense hypotension versus long duration of intense hypotension versus short duration of moderate to mild hypotension versus the long duration of moderate to like mild to moderate hypotension, and they categorized it accordingly. And what it found was that a short, even a brief duration of severe hypotension is associated with higher risk of post-operative myocardial injury compared with patients who have a minimal intraoperative hypotension, shorter duration of surgery, or both. Now, this is a crowded slide. I apologize for that, but this was a review conducted by Weslink and al., and they looked at 42 studies dealing with this. Once again, yellow suggests the low risk of developing, and the light brown suggests the high moderate risk, and the red or dark brown suggests the high risk. And up there on the left is the blood pressure, mean arterial pressure thresholds, which means top is less than 80 millimeters of mercury, and bottom is less than 40 millimeters of mercury. And in the second column, you have 1 minute, 5 minute, 10 minute, and 20-minute duration of hypotension. And it is just intuitively, you can see that the more severe the hypotension, and then it becomes independent of the duration of hypotension. So severe hypotension, but what is important and why I'm showing this slide is that this didn't looked at more than one outcomes. And on these outcomes included these outcomes, these outcomes included neurosurgery and neurological damage. These outcomes included the chances of these patients developing delirium, and these are two columns which are showing risk of neurological injury and post-operative delirium. And what we can see is that a presence of hypotension, surprisingly to us, was not an independent predictor of post-operative neurological dysfunction or delirium. That's another subject. If for time permitting, I'll just spend a couple minutes on that, because we are kind of. So now that we know that intraoperative hypotension is harmful, what can we do about it? And as I said, I'm not talking about interventions. I'm just trying to point to some areas of research that are of importance today. And so what we are looking at is, what we do is we respond to hypotension. So our attitude generally is reactive. The maximum we can do, or we do, is follow what is done in this surgery. What we do is we try to predict the patients who are likely to develop post-operative intraoperative hypotension on the basis of certain information, like this study has shown predictors of hypotension after general anesthesia, which means a baseline of less than 70 millimeters of mercury, age greater than 50 years, propofol induction, increasing fentanyl dosage, and ASA 3 and 4 patients. So we identify those kind of patients. And then what we do is we maybe put an arterial line in that case, maybe be a little more vigilant, maybe get our presses ready. But we are always reacting when the hypotension occurs. So and our reactions are generally based on like giving a bolus when the patient develops hypotension. Now, this study here, what they did was they actually, it was not a great study that had many design flaws, but still what they did was they divided the patients into two groups. One group received standard blood pressure management strategy, and that standard blood pressure management strategy was that whenever the patients had a fall in blood pressure below 80 millimeters of mercury, systolic blood pressure below 80, they would give this patient a bolus of phenylephrine. So that was the standard management in this group. In case of individualized treatment, what they looked at did was they started a norepinephrine infusion as soon as the blood pressure fell to less than 100 millimeters of mercury. So that kind of a bit with apples with oranges kind of comparison, but still what you find here is if you look at the times in randomization and the probability of post-operative organ dysfunction, and in organ dysfunction, they looked at all organs, respiratory, renal, cardiac, neurological, coagulation, everything failure. They found a persistent difference between the two groups. So what this study showed is that instead of that reactive standard management strategy that most of us follow, an individualized strategy wherein you identify that patient early and start a pressor infusion. And pressor infusion is just one of the ways of managing intraoperative hypotension. There are other ways which is beyond the scope of today's talk. Once again, Mathis and his group, what they did was they, based on identifying preoperative risk, they then quantified that whether patients who had a greater preoperative risk had a greater likelihood of developing postoperative acute kidney injury if they developed hypotension. And they managed to say that, yes, if the patients were at a greater risk, they were more likely to develop acute kidney injury after developing hypotension. So in this way, they were actually saying that you identify these at-risk groups and treat more aggressively the intraoperative hypotension and preempt instead of reacting. And this is just a very crowded slide showing the risk factors that they had identified, and they had developed a scoring system based on that as well. Now comes the real thing, and just 2 minutes more. And this is where the future lies. And the future lies in machine learning and artificial intelligence. Because what we are doing is we are basically responding to, or at best based on some preconceived assessments, predicting a patient who is likely to develop hypotension. But still, we start managing the patient when hypotension occurs. And as I said earlier, and as the data is suggesting, that even that brief period wherein we are reacting may actually be when the patient is vulnerable, and the vulnerable population is more likely to suffer organ damage and die. So if there was a way of predicting these patients early, and then predicting episodes of hypotension early. So there are three approaches towards that. Two actually on, and the third one is another one which is based on machine learning and artificial intelligence. So this deep learning model, what it does is it takes data from more than one monitors, which means arterial blood pressure, ECG, plethysmograph, capnography, and looks at that very, very subtle changes. So they took a large data and this is the kind of for people who are interested in research, we can it's a separate subject. So there was this validation cohort, and then identification cohort, and then validation cohort. And this for the first they identified those risk factors and then went on and validated those training and validation kind of cohorts. So they identified those were able to, based on this, able to identify those subtle changes wherein you can predict onset of hypotension about 10 to 15 minutes before you actually observe that hypotension episodes. And this is on the basis of those subtle changes in arterial blood pressure, ECG, and all this, which a naked eye or our mind is not able to process because of there's so much our processing capacity of our minds, brains. So this machine learning algorithm, once again, now this algorithm is based on purely on your arterial pressure waveform. So this looks at those subtle changes on arterial pressure waveforms. And once again, they tested this algorithm on something like 500 and more than 500,000 data set of arterial waveform recordings, and then looked at those subtle changes. And then this algorithm I started to identify hypotension about 10 minutes before the actual hypotension was observed or looked or identified. So this is where though you are actually preemptively treating hypotension before it occurs. And as we know, artificial intelligence and machine learning, they have got a way of actually then enhancing their learning once those algorithms or once those learning, what we call that, those initial teaching algorithms are taught, then they go on and learn and keep on learning and keep making themselves better. Here, this is another way. What they did was they looked at very, very complex, lots of data set, which you find, and on the basis of that, this algorithm actually identifies patients who are likely to develop hypotension, but unlike our existing kind of scoring systems, this is a far more complex, and this actually individualizes the patient instead of just taking them as a category. So this, on the basis of these algorithms, what we will see in the future is that we can suggest that this is the patient where we are going to put in the arterial line. This is where we are going to start this, the process early. This is the patient wherein we are going to not go for propofol induction. So these are those interventions that we'll be making, or give a little more fluid and all that. So this is the way this very complex analysis, which identifies patients who are at high risk versus patients who are at low risk, depending on the data set that we are giving on the preoperative information. Now, I'll conclude this with reference to our perioperative quality initiative work group led by Sessler, who has done tons of work in this area of perioperative care. So they've got together a group of experts who then gave 3 consensus statements and identified few areas for future research. So consensus statement number 1 is that intraoperative mean arterial pressure below 60 millimeters of mercury are associated with myocardial injury, acute kidney injury, and death. Systolic blood pressure below 100 millimeters mercury are associated with myocardial injury and death. Injury is a function of hypotension severity and duration. So statement number 1. Statement number 2, for adults having non-cardiac surgery, there is insufficient evidence to recommend a general upper limit of blood pressure at which therapy should be initiated. So they're not talking about hypertension. The third consensus treatment is that during cardiac surgery, intraoperative systolic blood pressure greater than 140 millimeters is associated with increased 30-day mortality, and injury is a function of severity and duration. So these are three consensus. So from whatever knowledge we have got, this is the conclusion. However, I will add the caution to it that below 55, we are talking about, even for a brief duration, a very kind of adverse outcomes in terms of acute kidney injury, myocardial infarction, and death. The questions that are still to be answered, at least were unanswered by 2018. I haven't seen them being answered after that. I looked in literature. So do organ-specific thresholds for autoregulation exist? And if so, how they are altered by factors within the perioperative period? Which component or components of intraoperative arterial pressure best predict adverse outcomes? Do different monitoring techniques result in different association between threshold pressure values and adverse outcome? Does target blood pressure management affect outcome? And do various causes of alteration blood pressure affect association with treatment outcome? So these are those unanswered questions that this group has requested. So I will stop my presentation there with, and thank you for being patient, and thank you because I crossed the upper limit given to me by Dr. Asma by 5 minutes, with the disclaimer, with a kind of confession that I did get used from help from ChatGPT in identifying the landmark studies. I did my own search and then asked ChatGPT. And by the way, I'm using 3.5 and seriously considering buying for the version 4. And it actually identified these studies which I had so wonderful work. It did in 15 seconds what had taken me about 3 days to do. Great work. Thank you very much.
Thank you so very much, Dr. Arshad Taqi. So now when you have given your disclaimer, now we can have another talk of yours on how to accurately use ChatGPT for academic purposes, because I am quite sure that most of the people would be using it, but in a right way and doing it accurately is quite a challenge for many of the people, including my own self. So we would like to hear you again on that topic as well, inshallah, soon, or maybe whenever you feel like doing so. So now we will be open to questions, and I would request everyone to kindly send your question in the either chat box, or if the question is quite non-understandable, then I would be requesting the participant to unmute their voices, and then they can ask directly. So now we have a first question from Azhar. He's asking, what is the recommendation for intraoperative permissive hypotension nowadays?
Oh, interesting,
Permissive
because
hypotension.
I had intended, and I actually put in a slide and then took it away because that would have opened another Pandora box. So yes, because that's the first thing that comes to our mind. So if hypotension is so bad, then how about in those induced hypotension, because the surgeons keep on demanding that. So I searched the literature for that, came across 3 interesting studies. First was from orthognathic surgery, which said that two studies from maxillofacial surgery, which said that which had 2 conclusions. In those cohort of patients, they did not find any evidence of harm to the patients as a consequence of intraoperative hypotension, but that was the problem was that they had not defined the limits of hypotension. They had just vaguely defined the criteria. Then there was another study which was more like a non-structured review in orthopedic surgery, and they only addressed 2 things, and that was that the need for blood transfusion was less and bleeding was less. They did not address the issue of myocardial infarction, acute kidney injury, or composite of those 3, which actually causes harm. The jury is still out. We don't know. So far, we don't have any evidence, because this large data set, the problem with this large data set is that it did not address, like when you're dealing with 330,000 patients, they did not look at individual surgeries. They did not look at the interventions to correct hypotension. They did not look at whether this hypotension was deliberate or kind of unintended. So we still have a lot of unanswered questions. What we know is that these patients who developed complications as a consequence of blood pressure less than mean arterial pressure less than 55 were included patients who had no other comorbidities. So we have to be conscious and we have to start looking at. So what I would suggest is that this could be a study, an invitation to form a registry, which means we could go ahead and actually jointly start collaborating and gathering data on patients on whom we do those controlled hypotension and look at the limits of hypotension and go on and kind of look at their creatinine levels on day 2 and troponins maybe as a part as a research funded project. I think let's think about that. So for a change, this would be something coming from Pakistan.
Inshallah, let's hope for that as well. So we have 2 more questions, and I think both of them are addressing the same. And it's by Ali and Salek Zahir. They are asking to have some few words or study regarding the management of intraoperative hypotension. And the other one had also the similar question: what is the best method to control hypotension?
See, I deliberately avoided this topic because it's complex. But the first thing is, we are talking about vasopressors, which is generally considered the first line treatment because most of the hypotensions that we come across in our standard daily practice are vasodilator induced, and also because of partly the response to response to vasodilatation is obtunded because of the anesthetic agent. So generally giving a vasopressor. So most of the studies we are looking at are comparing one vasopressor versus the other, phenylephrine versus norepinephrine versus whatever, and also boluses versus infusions and that kind of stuff. But we need to understand that unless we look into the pathology of that hypotension and make sure that we are treating vasodilatation, then vasopressor alone may actually not only be insufficient but harmful as well. The patient may require a bolus of fluids. The patient may actually have myocardial dysfunction. So that's why starting from that, every piece of information that we have in arterial waveform, a plethysmograph, the capnograph, and blood pressure, and once again the reperfusion based on that. But if I got a patient who suddenly had a low blood pressure, my first response would be to give a vasopressor and bring the pressure up while I'm trying to look for the definitive cause.
Right. So this also answers the question of Dr. Naseem Javed, who has asked a similar question regarding a 45-year-old female patient, hyperthyroid and now euthyroid, undergoing for cholecystectomy. And now his question is that if a patient experiences hypotension with bradycardia intraoperatively, and hypotension meaning here that the mean arterial pressure is 72 after 10 minutes. So how can this be appropriately treated? So I think this also answers his question as well.
Yeah, I mean, but if it is hypotension with bradycardia, naturally what every one of us would do is give a small bolus of epinephrine instead of norepinephrine.
Exactly.
So what we have in our practice, we have 2 syringes drawn for every patient, and that is irrespective. At the side, on a side, properly labeled, away from the normal standard drugs, which is 1 atropine diluted in 5 mils, which is 0.22 milligrams per ml, and 1 syringe with 10 mics per cc of epinephrine. And the second syringe which is lying on another side is epinephrine 100 mics per cc, from where you draw that 10 mics for dilution. But these are the 3 syringes that we make sure that they're there for every case. We discard them after each use. We are wasteful in that, but we do not compromise on that one.
Yes, sir, because gone is the era when we had ephedrine, and ephedrine was being used for such kind of conditions where we had to treat only the pressures and not worrying about the heart rate. So yes, that is quite right that we can use the epinephrine in smaller dose and keep it ready, especially in those areas and in those circumstances where the monitoring and the resources are not available for the district health hospitals, or the hospitals where major facilities are not available. So coming to the other question, Syed Shah has asked. He has asked about AI, but hopefully we'll be covering that in some other lecture from you. So Khan Dost Afridi has asked that if systolic blood pressure remains below 70 for 4 minutes after it is kept within normal limits, then how it can lead to death after 1 month. So he's actually asking about that mortality
I think
related to.
that's an excellent question, because see, the point is that when we have a period of hypotension, it's not just that the blood pressure went low and then it went up and everybody lived happy hereafter, because that period of hypotension can give rise to a cascade of events. The most important, and we should not forget, the concept of reperfusion injuries, oxygen kind of toxicity and all. But when we have a period of hypotension followed by normotension, then we are talking about reperfusion. And second, in the kidney particularly, and please remember that most of a lot of patients that we are dealing with who have an apparently a creatinine level of something like 1 or 1.1 or something, and we are happy that the renal function is all right. The renal function is not all right. Renal function, the creatinine, normal creatinine level is because that's where the kidney is working. But if you really went in with the tools and used those cystatin and all that tools and measured their eGFR, their eGFR would be borderline. And now what you're doing is you are actually kind of risking putting this patient into a cascade wherein this patient may develop acute kidney injury in 3 months or go on dialysis in 3 months' time. And that actually, I can tell you, that happened to one of my patients. I came across a doctor. We were sitting there and she said, well, you gave anesthesia to my mother. And I said, yes. So how is she? And she had a bilateral knee replacement. And I said, how is she? And she said, she died. And I said, what happened? And she said, 5 months later, she went on dialysis. She was on dialysis for 3 months and then she died. So she got 2 knees, which she never got to enjoy in her life. So we went back and looked at our records. And that patient had a creatinine level of 1.15 or 1.2. She had a period of during her first knee, she had a brief period of hypotension. We gave her fluid, some pressors, it stabilized. At the end of one, we told them that, look here, let's not go out with the second one. And they said, fine. But the lady's son had come from the States and he said, so is she okay now? We said, yes. He said, then go ahead, please do it because I have come here and let's just get it done. But I'm not taking the responsibility away from me, but I have witnessed that in my life and I'll never let that happen to me again or to my patient again.
Sir,
I hope that
do
answers
you
the
really
question.
think that that was the exact reason for her death, like her passing away, for that brief period of hypotension? Do you really think that was the cause? Are you convinced?
No. That's a very interesting question because all the studies that I've cited, are looking at, even if they are prospective, none of them is a randomized controlled trial. They are all kind of case control studies, cohorts, which means you are looking at association and not causation. The only way to determine causation, as our science knows today, is an RCT. So in the absence of an RCT, this is a cause in association. So what we are saying here is that a brief period of hypotension is associated with altered renal function. And what they have done in study after study after study is that they have made sure that they have actually looked at all other factors. Those what we call as confounding variables have been statistically taken out, and then the only causal link that remains, and the data is so strong, and the kind of the correlation is so strong that we are forced to assume that this is, and then there are physiological mechanisms which explain that. So I would say yes.
Oh, okay. Maybe we require more studies on that, obviously, because that was one of the cases which you just encountered. Maybe later on, science would prove, and it's quite possible that the cause was not identified rightly at that time, and later on it was more evident in the form of a brief period of hypotension. That's quite possible. So coming to the next question, Mohammad Tahir Munib has asked, are there any recommendations for monitoring or follow-up those patients who have a hypotensive episodes during anesthesia?
Yeah, well, of course, the first thing would be that don't let it be repeated. I mean, that's so post-operatively, the care process should carry on. We should not, we need to be more vigilant, and then we need to be, the most important thing is, and the most kind of, it's very important to understand that we cannot improve unless we learn to stand up and say, well, this has happened. Sometimes we may be able to do something about it. Sometimes we may not be able to do about it in that particular patient, but at least by accepting that this has happened and following it up and following the outcomes, we will be wizened for the future. That's how people learn.
That's very true, and that's such an important message to each and every individual who is present here right now, that kindly and please do not only it's not important to, it's equally important, I would correct my words, that it is equally important to monitor and clinically have the patients treated, but it is equally important to register those cases, those events, and get it published, or at least get it notified on certain level at some point in time, so that everyone becomes aware of those complications or those events, and then patients can be saved accordingly. So despite of the fact that we are running out of time, I'm taking the one last question, and then I would request Dr. Akhtar Waheed and Dr. Shabbir Jamani, being the president of PSA Karachi, to have their final words. So Aisha Asad has asked, does cause of hypotension affects the outcome like blood loss and other causes? I think she's trying. I think she's trying to ask that the other causes of hypotension, like blood loss, does it affect the outcome?
So yeah, Aisha, sitting in greener pastures, Aisha can afford to ask these kind of questions. But anyway, that's kidding. See, the data which I shared, and they did not address the cause of hypotension. They just looked at episodes of hypotension. So that episode could have been because of blood loss. That episode could have been because of cardiac reason, vasodilatation, whatever. That was irrespective of the blood loss. And that's the problem with that kind of data. For that, you need more information. And I think one of these questions that the Sessler's group has identified is whether the cause really matters, or the interventions really matter, or is it just that if you have had that hypotension, irrespective, that in itself would be enough?
Ma'am, I also have one question, if you allow me.
Yes, please go ahead.
Sir, how much it is important for us to be familiar with these studies and trials while preparing for any subject or topic? And if these are important, what is the minimum out of these studies which we must know?
But now I'll just tell you how I mean, at this point in my life, I am not studying for the exam. I have that luxury of going and reading what I am really interested in. But even when you are appearing for the exam or preparing for your next day's cases, what I am doing these days is, and what I would strongly recommend is, if you have a subscription to Up to Date, just open that and they will give you a summary of the recent literature. Yes, you have read your textbooks and all. And then if you some of that statement or statements interest you, then you can go on and follow up the references and read the studies. I mean, it's not mandatory, but it's always nice to know the science behind what the statements that the books are making. I mean, I read my Morgan tells me something. I'm interested in finding out, where did Morgan find this from? I mean, he wasn't born, or it didn't come to him as some kind of a divine revelation. He just found it out. And so how did they find it out? And what is the basis of this person or this author making this statement? So that's why it's important. And if we get that challenging attitude, then questioning attitude, then what we'll find is that there are times when we realize that the concepts that we have made were basically had some flaws which were corrected as the basis on when you go and read those studies. I hope that answers the question.
Sir, thank you.
Thank you so very much, Doctor.
Sir, can I ask one question?
Well, can it be please last
Hello?
one, because we have already run 10,
Yeah.
15 minutes.
This is the last one. Sir, thank you very much. Very elaborative lecture. And now I am more worried. During intra-op, should I worried more about intraoperative hypotension or hypoxia?
Both. Both. I mean, there's no, but I mean, both of them have the potential to harm the patient. Best in terms of cerebral perfusion, and I'm not trying to lessen the impact of any one over the other, but if a patient has had a period of low half hypoxia and the cerebral blood flow was maintained, that person's chances of survival are better than the patient who has had a period of no flow. I mean, and once again, with the disclaimer that I'm not trying to say that we should tolerate hypoxia. No, hypoxia is equally bad, but we don't know at this point the limit of hypoxia, which is incompatible with survival for a certain brief period of time. But we certainly know the limit of no flow or low flow, which is incompatible with life over a brief period of time.
Thank you so much, sir.
Thank you,
so
sir.
much,
Thank you
Dr.
very much.
For any further queries, kindly leave your questions in the chat box. We will ask Dr. Arshad Taqi, get his answer, and then we'll send the answers to you in the emails provided to you for the e-certificate. So before we end, can we have, because we also have our one of our very beloved teacher, Dr. Akhtar Wahid Khan, he's also with us on in the participants list. So can you, sir, please unmute yourself and have a few words with us before we take the final words from Dr. Shabbir?
Well, you remember I wrote to you this afternoon that I have known Arshad for decades. So naturally, it was not possible that I should meet miss his lecture, which has been happening with other lectures. So I thank you also that you very quickly helped me. I was in a position to hear. I remember
We are
Arshad.
honored, sir. We are honored with your presence. That means a lot to us. Thank you so very much for
I
joining
remember
online.
Arshad from Buenos Aires also. Buenos Aires, Argentina.
Sir, let me take the liberty of saying this in Urdu, Dr. Asma, because ये मैं किसी और ज़बान में एक्सप्रेस नहीं कर सकता सर. बहुत उधार हैं हमारे ऊपर आपके. बस मैं इतना ही कह सकता हूँ.
Bilkul, that's absolutely right.
Thank you. Well,
Thank
shukriya.
you so much, Dr. Akhtar Wahid, sir. It's an honor for us that you joined us late this night. And for as a final words,
No, I was
can
in
I
time.
please,
I was in time.
sir?
The
Thank
lecture
you so very
started.
much.
Oh,
Can we?
yes. I was in
Thank you so
time.
much, sir. Thank you so much, sir. Can we have our last words from Dr. Shabbir Jamani, President, PSA Karachi, please?
Thank you very much, Dr. Asma, for asking me to comment and give me a few of my words. First of all, I'll thank Dr. Akhtar Wahid Khan for joining, this lecture. And I must say that I have the honor of learning from him and working with him at Lafayette National Hospital in late 1980s. And that was a wonderful time. And he taught me what he should, and I learned a lot from him. And the time which I spent with him, I'll carry on this time with whole of my life, And thank you very much, Dr. Taqi, for a wonderful lecture. It was a classical example of good time management and excellent presentation of recent guidelines and evidence-based practice. I can safely say that we are the only society who's organizing these types of online lectures on regular basis without any break. And the credit goes to Dr. Asma and her team indeed. Thank you very much, Dr. Asma, for organizing this beautiful series of lectures.
I think this is not possible without the presence of our faculty, esteemed faculty who are present every time, and that's why I'm especially thankful to Dr. Shataki for joining us online at late at night. Like 8 o'clock is like too late for most of the people, but equally thankful to all my participants who join regularly and who really are interested in these lectures, that they ask questions and their questions are being answered by our faculty members. So really grateful to you, sir, Dr. Shataki, for your detailed description on hypotension, because the way you have described the latest evidence, even it enhanced my knowledge as well, being being one of the faculty. So I'm quite sure that those residents who could not join because they have upcoming IMM exam and the part 2 exam in this week, they really missed it. But this was quite, an updated lecture which helped the upgrade the knowledge of many of us, including my own self, sir. So I'm really grateful. Thank you so very much. And
Thank
I
you.
really hope that we will be having you on board for other lectures as well. So thank you, sir. Thank you so much.
Thank you very much. Thank you very much.
Thank you so much. Thank you, everyone, and have a good night. Thank you. Allah Hafiz.